Hello, and welcome to the Musella Foundation's Brain Tumor Webinar Series. Tonight's topic is GammaTile, and today's speaker is Dr. Randy D'Amico, who is Assistant Professor of Neurosurgery at Lenox Hill Hospital, which is part of the Northwell Health System. Take it, Dr. D'Amico.
Hey, everyone. So my name is Randy D'Amico, and it's a pleasure to have been invited here to talk about GammaTile and kind of how I use it in my practice. So who I am a medical doctor, apparently. No, I'm an assistant professor of neurosurgery at Lenox Hill Hospital. It's part of the Northwell Health System. And I work at Lenox Hill Hospital in Manhattan. And I'm director of the Center for Brain and Spine Metastases. And I focus really on oncologic disease and the surgical treatment thereof in the central nervous system. So brain tumors and spine tumors. You may know Lenox Hill. There was a documentary on Netflix that was, I think, fairly well received. And you got to see two of our doctors participate in that. But really, you know, the Northwell system is a huge system. And we have a huge cancer network that we're, you know, actively developing, especially given our location in the Northeast where there's a lot of major centers around. And I came from Columbia, that's where I trained. And since I've been here, I've been nothing but impressed in the quality of care, the cutting edge aspect of care that we're able to provide in a large system with a lot of resources. And so what I wanted to talk to you guys about today was really brain tumors. And brain tumors come in kind of three shades that are relevant to a discussion on GammaTile, right? And so we've got brain metastases, which are, you know, without a doubt, the most common type of brain tumor that people get. And we'll talk a lot about what these are and where they come from. Gliomas are tumors that arise from the cells within the brain. It's something goes wrong genetically and the tumors kind of transform, and then they actually recruit other cells into the tumor around them. And these are devastating diseases that we haven't made a lot of progress in, although, you know, we've made some, but not significant in terms of how people do. Meningiomas are benign tumors generally that grow on the lining of the brain and tend to push the brain out of the way rather than infiltrate it like a glioma or a brain metastasis would. They come in three shades. You know, there are more aggressive forms and less aggressive forms, but in general, that's kind of what we deal with. And then there's a variety of other tumors that arise in the brain that are really not as relevant to this discussion. They can come from glands in the brain. They can come from the lining of the brain. They can just be from the neurons themselves in the brain. But the three that we really deal with on a regular basis are the metastases, the gliomas, and the meningiomas. So what is a brain metastasis? So a metastatic brain tumor, a brain metastasis, is what we consider a secondary tumor, meaning that you've got cancer somewhere else in your body, and the cancer cells are able to kind of leave that tumor and enter the bloodstream and travel to different parts of the body where they lodge and they grow. And these are 5 to 10 times more common than any sort of primary brain tumor, like a glioma or a meningioma. And they like to go to the cerebral hemisphere. So we see them on the top of the head, sometimes in the cerebellum. These things can also go to the spine, but that's a little off topic for this conversation, so we'll leave that to another time. When does this happen, right? So you get diagnosed with a breast cancer or lung cancer, and you know what can you identify as the real possibility that you're going to have a brain metastasis? So some appear many years after the primary cancer. We've gotten very good at treating primary systemic disease now with chemotherapies and immunotherapies. And so you may do very well for a long period of time, and then some residual cells that got into the bloodstream pop up in your brain. Some metastasize so quickly that they're identified actually before the primary cancer. So people present to us, and their first presentation of a systemic cancer, a lung, a breast, you know, a colon cancer, is a lesion that went to the brain. And other times, speculated, but it's difficult to say, that we think that the body can actually destroy the primary cancer, but not the metastatic cancer. And that's due to something called the blood-brain barrier, which we deal with on a pretty regular basis. Basically, the blood vessels in the brain have very tight junctions that don't allow, you know, the body's immune system or chemotherapies to enter it. And so you have this protected environment within the brain where tumor cells can enter and be safe and grow. And people always ask, well, how do you know if you have a brain tumor? And so brain tumors have a variety of symptoms, and these symptoms are primarily based on where the brain tumor arises. So it may be as simple or as general as headaches. It can present with seizures depending on the location. It can present with weakness in the arms or legs, depending on the location, balance issues, especially in the back of the brain here. You can demonstrate memory loss due to swelling around the tumor or where it's located, speech problems, behavior problems, vision problems, or rarely hearing loss, and sometimes numbness. The bottom line is when you think you have symptoms that are not getting better, that are getting worse, you're worried, you're suspicious, you talk to a provider, right? And your primary care doctor can then order the studies that are really important for diagnosing this. So what are those studies? So we talk about CT and MRI. These are scans of your brain, all right? So a CAT scan uses X-ray and MRI is magnets. MRI is more really specific. It gives you the really good resolution that you can identify all the relevant anatomy. But a lot of times these things are picked up just on a kind of surveillance CT scan. Biopsy is the ultimate for diagnosis. That gives us tissue. It gives us a piece of the tumor that we can run our tests on and say exactly what this is. And then a PET study, some of you might know, is a nuclear study where you ingest a solution and then you go into a scanner. It can see areas of metabolism suggestive that there's tumor growth in these regions. And now the most important thing to understand is that metastatic brain tumors are treatable. And we've gotten very good at controlling these. And the way we do that is we tailor it based on what kind of tumor you have. So it depends on the type of the primary cancer and what type, if any, chemotherapy or immunotherapy you would be a candidate for. And then really, does that chemotherapy allow access to the brain, okay? Because of that blood-brain barrier that I mentioned before. But then we also think about, well, how did you respond to previous treatments? We think about how your functional status is. What we don't want to do is give chemotherapy to people who are very sick because they might get sicker. And then obviously the number and location of tumors in the brain, someone with one tumor that's easily accessible versus 20 tumors that are kind of spread everywhere, very different prognosis, very different treatment algorithm. And then the general health of the patient and what they want, as well as what their symptoms are. So a lot of times when we do a surgery, it's to relieve symptoms that are being caused by the brain tumor, as well as pressure inside the head. And so surgery is what I do. And so this is where, you know, I think almost every neurosurgeon is involved in the care of an oncologic patient at some point, all right? And so when do we do surgery? Okay? So we do surgery for large symptomatic lesions in patients who are relatively healthy, who have a lot to gain. They have good, what we call functional status, all right? And what we do with surgery is we allow fast relief of the mass effect. So if you think about it, the tumor is pushing in the brain and the skull is a box. So you're adding mass into this box, which is going to increase the pressure. So by taking out the tumor, even if we don't get the whole thing, we're able to reduce the pressure inside the skull. It allows us to get that biopsy I told you about, which is so critical. It allows us to get tissue. The issue is tissue, people used to say all the time. And allows us to then take that tissue and run genetic tests on it, molecular analyses, histopathological, studies that tell us exactly what it is, but also in kind of the current era of cancer therapy, also allows to target therapies for you. And so the indications basically come down to when is surgery right for you? It's when there's a clear correlation of a deficit, meaning a problem, one of those problems we discussed, speech problem, motor, language, the ability to move an arm or a leg. So there's a clear correlation of that with the location of the tumor. But also, your primary systemic disease needs to be treatable and under control. And in general, we won't do surgery for 20 lesions. So you have to have one or two, maybe a few at most, that are close together and safe for removal. And we've done very well with this disease. And so surgical resection plus radiation in patients with single metastatic lesions have already been shown in large trials to improve survival. It decreases the rate of recurrence. It improves quality of life compared to people who are just given radiation alone. So we've come to learn that we need to be aggressive here. We kind of have set this standard of less than 4 metastases, if we can get them all out, as a reasonable option. In general, I'd say that this is rare, 1 or 2 maybe, because we've gotten so good at radiotherapy and stereotactic radiation that we can really get excellent control rates by using that. So we tend to go after the symptomatic lesion or the largest lesions. Prognosticators here, we have to worry about things like, did it take long for this to recur? How many lesions there are? An RPA classification is a classification we use to analyze the likelihood that you will benefit from a surgery. And then obviously the completeness of the resection. You want to get out all of the disease you see in the brain if possible. Now, We can't get every cell, and that's why the radiation is still necessary in the chemotherapy. But we can take out the bulk of the disease, and that's been shown to improve outcomes. When you look about the median survival of patients with brain metastases, meaning, the importance here is to understand that once you have a brain metastasis, you're stage 4 disease by definition. And you can see that we do pretty well. Some cancer is worse than others. These are, older stats, but you can see what the error bars are on this as well. And, melanoma out to almost 2 years, breast out, even farther. And our lung cancers, we're doing better with, especially with the, influx of new adjuvant therapies. And so what's the problem? And this problem actually goes beyond brain metastasis. It involves gliomas and meningiomas that we were talking about. And the problem is that brain tumors recur. And so we cannot take a margin of healthy tissue because the brain is important. I like to say brain good, tumor bad. And so you're able to remove the tumor, but you can't get the microscopic cells that might have invaded. The cells are always left behind. And then on top of that, you just did a surgery. And so radiation, which treats basically cells that are cycling, will influence your wound healing. So in general, we have to wait about 2 to 4 weeks after a surgery, sometimes longer, for the skin to heal before we can start radiating. During that time, any of those residual tumor cells are growing. They've been untreated. And so we have a few options here. Number one, if it comes back very, very quickly, we can always do a repeat surgery, although this has diminishing returns because now you have a repeat, an open incision that was repeatedly opened, which means it's going to take longer to heal. You can't get repeat radiation to the same area in general using the standard techniques because the areas on the way or the areas around it can be injured that way. And like I said earlier, our current chemotherapies are not that useful here because the blood-brain barrier is so efficient at stopping transmission of these drugs into the brain tissue. And that's where GammaTile came in. And so what is GammaTile, right? GammaTile is an FDA-cleared, safe and effective targeted radiation therapy for patients with brain tumors. And what it is this bio kind of resorbable, flexible collagen tile. And inside of it, and you can see in the cross section, over here and on the next slide, that there are seeds in there, these titanium seeds that have a radiation source. And this is a cesium-131 source. It's got 4 seeds per tile. And these tiles are placed within the resection cavity at the time of surgery. So you remove the tumor, you're left with a gaping kind of hole where you took the tumor out, and you line these tiles along the cavity. That's about an additional 5 minutes to surgery. And the tile itself, the way it's built, has a spacer. So the seeds are not in direct contact in the brain. What you don't want is you don't want to put radiation seeds on the brain because that could cause treatment effect and problems with the brain tissue. And so this allows you to space these things properly, and it's measurable. And that way you can actually, number one, clearly identify the dose you're given. But you're also optimizing the dose because you can pre-plan how many seeds and tiles you're going to need. The nice thing also is that this is covered now by Medicare and most private insurance plans. And this is something called brachytherapy. All right. And so brachytherapy is instead of sitting in a machine and having radiation go through you, the radiation's inside the tumor cavity. And so it provides this immediate dose of very intense treatment immediately at the surgical closure. And on top of that, we have good evidence now through many, many patients who have been treated with this across the country that the use of GammaTile extends progression-free survival with minimal associated complications. And I think probably the most important part, there's a reduced burden on the patient and it ensures compliance, all right? Instead of having to go home, make an appointment with your radiation oncologist, come back for treatment, whether it's 3 days, 5 days, 6 weeks in certain gliomas, you just go home. The radiation's doing its job from day 0, really, in the operating room. And so how does it work, right? And this is kind of more of a discussion on how radiation works, but it disrupts tumor cells from replicating. So the radiation that's deposited in the cavity in the wound lining the normal cells travels through that tissue a short distance, and it damages the tumor cell DNA so that the tumor cell is unable to replicate, and then it undergoes kind of automatic death. And the collagen tile that we place in the operating room, we glue it in place, it stays in place. So there's no movement, all right, while you go about your daily business. An important thing about cesium as a radiation source relative to some other types that we've tried is that the half-life is short, 9.7 days. And so you're getting 95% of your dose by 6 weeks. That's usually the start of treatment in a lot of glioma patients. For brain metastases as well, most people err on the side of safety and won't start for about 4 weeks. Whereas again, for those 4 weeks, you're getting treated and you're getting all the dose in that time period. So, immediately after surgery, there is the least amount of tumor cells left in your body, which means that this has a better chance of affecting the change. After about 100 days, these tiles in your head are no longer doing anything. They're free of radiation. They sit there. They do not need to be removed. The collagen itself gets resorbed by your body. And so, you're done. That's it. And so, this is a treatment comparison. And so this is a post-op CT of a patient who had surgery. You can see those metal dots by the arrow are the seeds themselves, okay, lining the cavity. And what this is showing you here is the radiation distribution on the right. And you can see you get this really beautiful, compact circular area of treatment versus our standard, what's called intensity modulated radiation therapy, which is traveling through your body, right? And so you're getting all this spillover into normal regions, right? And so here in the parietal lobe, not that big of a deal, but when you're in regions that are close to, let's say, the nerves that control your vision or your speech areas or your memories, these areas are affected. And so GammaTile allows a really precise dose distribution right in that area where cells are going to be left behind that are going to generate a recurrence. And so, my group actually recently published a systematic review looking at cesium-131 brachytherapy. Not all brachytherapy is GammaTile, although I think, it certainly is a nice way to do this and make the job easier. And so what we found, looking through all the literature using brachytherapy with cesium, was about 279 patients with 293 tumors, which makes sense because there's metastatic lesions. People have multiple mets. And when we break that down, you can look at about 184 brain metastases, and these were newly diagnosed brain metastases. 66% high-grade glioma and 43 meningiomas. And this is what cesium has been used on in the past. So we have a good source of information here. And what I find interesting about this, and it speaks to really the indications about how even I use GammaTile, is with brain metastases, we really have an option here, right? If you look traditionally, and this is across the country, this is across the world, really, 72% of people have used brachytherapy on newly diagnosed metastases, meaning this isn't a tumor that came back, although that's very possible to use as well, because you're allowed to deliver such a high dose of radiation focally. But when you look at gliomas and meningiomas, people are really using these on recurrent lesions. And, the main reason there is that, with high-grade gliomas, the treatment, the disease is tough and the treatment paradigm is hard. And in general, patients want to get on clinical trials. And clinical trials have to be written by something called the Institutional Review Board. And a lot of times they'll limit what kind of treatment you could receive before your clinical trial. And so sometimes in an effort to limit the ability of GammaTile to limit your treatment, people won't use it. But when a glioma comes back, especially after a clinical trial, everything's out the window. There's no more rules, and you're also limited in your options. And so I think most people see GammaTile as at least an option when people don't have an option. And I think it's extremely valuable for that. Now, it's important to understand, though, this is just what traditionally has been done. We are very, very interested in actively looking at using GammaTile up front for initial diagnosis of gliomas. The glioma radiation schedule, as it stands right now, is 6 weeks of radiation, 5 days a week, versus going home after your surgery and just seeing your neuro-oncologist to start your chemotherapy. And so there's a huge potential benefit here that's being investigated as we speak. But, as with patients, they need to understand that it depends on what their goals are. If they want to be in a clinical trial, they have to, very strategically choose one that won't limit them. Or they need to put their faith in the GammaTile experience, which, I think is very, very reasonable. Also, just certain patient populations are better suited for this. Patients who are going to have poor compliance, who aren't going to make 6 weeks of radiation therapy because their family isn't around and they don't have transportation. So regarding meningiomas, meningiomas typically come out without any adjuvant treatment at first. And so the reason for this being such a high recurrence level is because when they come back, you're limiting your options. And so GammaTile provides an amazing option for a recurrent meningioma. What we found when we looked at the side effects of this, and I think that's probably the most important thing that people need to think about, is that there's something called radiation necrosis. And this is a treatment effect of radiation where the tissue around the tumor cell actually is hit by a high dose of radiation and it dies and it causes swelling in the brain. The GammaTile, and most likely because of its tighter kind of area of action, had a lower rate of radiation necrosis across the board, or at least on par with the best studies of gamma knife, which is an alternative source of stereotactic radiosurgery. And so we know that this is, non-inferior without a doubt, and maybe possibly better in terms of the ability to prevent the, radiation necrosis from occurring. We found a comparable risk of seizure, so 4.7%, which is comparable to what we see with other radiation sources. A 4.3% risk of wound infection, which is critical, right? When you radiate the scalp in a fresh wound, the skin can possibly not heal and people need to go back to the operating room. This causes stress on patients, it causes stress on doctors, and it delays care. The reason for this has to do with that millimeter margin where you're getting radiation delivered, that when you're in the brain cavity, you're barely radiating the skin, which is fantastic. And then really important, we looked at the recurrence rate. And so we saw a 25% recurrence of distant metastases. And for those of you who don't realize this makes sense, right? We're getting a 6% local control rate, meaning the tumor that you removed and you treated right there is not coming back. But you have metastatic cancer, stage 4 cancer. And so what happens is other tumors come back in different parts of the brain that weren't treated. This isn't a failure of gamma knife. This is the natural disease. What I think is interesting is a 14% regional, meaning that you are getting some spread of this radiation out past the cavity and tumors are not really coming back there. This is also a mixed data set, meaning that we're looking at gliomas and meningiomas here too. And gliomas come back almost always within 2 centimeters of the initial. So these data are a little bit skewed, but I still think pretty remarkable numbers. And then looking at, again, all these patients, progression-free survival, meaning no tumor recurrence, 10 months. Now, that's an average of all these patients, number one, with 3 very different diseases. But also, remember, a large percentage of these tumors that are looked at are recurrent, meaning that you've already gone through a portion of your care, and then you're getting an additional 10 months progression-free survival on average, which is fantastic. 60% 1-year overall survival, again, skewed probably by the high-grade gliomas and the fact that you're dealing with stage 4 metastatic cancer. But again, it's a very good number. And I think, every year counts when you're diagnosed with a terminal illness. And then, again, going back to the most important thing, I think about the compliance and the ease for the patient. You're also getting improved neurocognitive status, meaning because the radiation is not spreading to other regions in the brain, people are thinking better. Versus when you get a traditional stereotactic radiosurgery, we see, in some studies up to a 15% decline in that. And so that is a very important metric as well for quality of life, which is probably the most important thing in cancer. And so, this is just a table from that study, and I'll leave it up here in case you want to look at it, but you can also, pick it up and read it. And so I think, major centers have taken on GammaTile. I think that this is an extremely promising form of radiotherapy. We have it, we're proud to be partners with Memorial Sloan Kettering, with Mount Sinai, with Westchester Medical, MD Anderson, Cleveland Clinic, Barrows, Mayo Clinic. These are big names in cancer care. And when you get centers like that adopting a technology like this, I think that it speaks volumes to, the potential of this treatment. And so in my practice right now, I would say, metastatic disease, first and foremost, I think about this, recurrent gliomas, recurrent meningiomas, all are evaluated for using GammaTile at this point. It's kind of changed my thought process. It's an option at the end of sometimes at the beginning, but also at the end of every treatment plan. It's easy to use, it's easy to tolerate for patients, which is the most important thing. We're not doing anything crazy to a patient. And, we have good data at this point that the efficacy is there. And that's both for small metastases and large irregular metastases. I think GammaTile is offering a very important, adjuvant therapy that has the potential to offer a lot of options to a lot of people who didn't have options before. And I'm real happy to be a part of it. And so at this point, I'll take any questions you guys may have. Appreciate your guys' time.